Hi, I'm Lori from HIS Talk. Welcome and thanks for joining us for today's HIS Talk webinar entitled Electronic Prescribing of Controlled Substances is Here. What should you do? It's sponsored by Imprivata. I have just a few housekeeping items to mention before we get started. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit questions to our presenters at any time. You may want to take a moment to familiarize with that functionality now. The presenters will answer your questions during Q&A at the end of the presentation. Today's webinar is being recorded, so attendees will receive a link to the recording as well as a link to a PDF version of the PowerPoint presentation. Those will come in a follow-up email from us. We have three presenters today. Dr. Sean Kelly, MD, who is the Chief Medical Officer at Imprivata, will kick things off. Joining Dr. Kelly will be Bill Winsley, who is the former Executive Director of the Ohio State Board of Pharmacy, and David Ting, Founder and Chief Technology Officer at Imprivata. Now with that, I'll turn it over to you, Dr. Kelly.
Great. Thanks, Lori. Here's a quick overview of what we'll talk about today, starting with the compelling factors for EPCS and its benefits. We'll also review the regulatory requirements, the technology systems and processes that you would need to support EPCS, and some quick tips on how to get a project off the ground. So why are we here? Electronic prescription of controlled substances has efficiency benefits and can help you meet meaningful use, both of which are important, and we'll cover that today. But we're all here first and foremost, mostly because EPCS can help fight one of the top healthcare issues facing the U.S. today: prescription drug diversion and abuse. The DEA estimates that over 7 million Americans abuse controlled substances every year, and as an emergency physician, I watch this crisis unfold daily. At least one patient every week that I see comes in with issues of doctor shopping, pills, death, all sorts of terrible consequences of these medications being diverted and abused. And far too often I'm seeing these cases come in on almost a daily basis. Really, this is an epidemic across the country and probably the world. According to the CDC, there were more than 22,000 deaths back in 2011, with the rate that's going up constantly every year. And this is actually more than homicides and car accidents combined. So it's a significant health problem in the United States right now. The vast majority of deaths from prescription drugs involve opiate medications like Vicodin and OxyContin or oxycodone. As you can see on the chart, the number of deaths from these highly addictive painkillers has increased almost fourfold over the last decade alone. Today, they cause more deaths than overdoses on cocaine and heroin combined as well. It's important to remember that while a lot of the focus publicly is on narcotic medications, controlled substances include more than just narcotics. In fact, they include a lot of the ADD and ADHD drugs, anti-epileptic drugs, sedatives, and hypnotics. This topic touches a lot of lives, and while there is focus mostly on curbing drug diversion and abuse from the regulatory standpoint, we have to remember from the humanity standpoint that there are millions of patients out there who legitimately need treatment, and EPCS can facilitate this treatment as well as help curb abuse and diversion. And as you may be aware, the DEA recently passed a rule to reclassify hydrocodone combination products like Vicodin from Schedule 3 to Schedule 2. While the ruling is an important step to addressing the abuse of these drugs, the tighter controls also have the potential to make it more difficult for patients with legitimate needs to get their medications. These are actually the most commonly prescribed painkillers, so the rule will also change significantly and increase the number of prescriptions on a national basis. Fortunately, technologies like EPCS can help address these challenges and deliver a number of additional benefits as well. First, I think it's important to level set a little bit. What we're talking about here is not inpatient prescription of medicines or ordering through CPOE or computer provider order entry when a patient is in an inpatient scenario. What we're talking about here as far as workflows essentially is any time a patient is being discharged from a hospital or is seen in an ambulatory area of the hospital or out in the clinics or out in a PCP's office or other specialist's office, including in the emergency department. It's essentially whenever a medication is being written and prescribed that is then routed to a retail or outside pharmacy. If your providers are currently using electronic prescription for non-controlled substances, then you're probably already seeing efficiency and safety and medication accuracy benefits from these systems for the non-narcotic and non-controlled substances. EPCS can have similar benefits across the healthcare ecosystem, and increasingly providers are already more comfortable using e-prescription systems and actually would like to use them for controlled substances where the stakes are the highest. For hospitals and health systems, EPCS can improve patient satisfaction, can reduce the risk of medication fraud, and help meet e-prescribing requirements for meaningful use. As a reminder, Stage 2 requires that more than 50% of medicines be prescribed electronically. So with particularly the changes recently in the Vicodin prescription laws, this can significantly contribute to your meaningful use numbers. For physicians, EPCS increases efficiency by eliminating dual workflows for prescribing. I can tell you this is a source of incredible frustration for us physicians and other prescribers. Enabling a single efficient workflow for prescribing would make us very, very happy, more efficient, and better able to care for patients in a safe manner. It also minimizes exposure of our DEA number, which can be the source of fraud. While EPCS delivers a number of substantial benefits, controlled substances are actually highly regulated, so the DEA has specific requirements that must be met before providers can start prescribing controlled substances electronically. To explain the DEA rule and how to think about the regulations, I'll turn it over to Bill Winsley now, who's the former president of the National Association of Boards of Pharmacy. Bill?
Thank you. As Dr. Kelly mentioned, the DEA has issued an interim final rule. They did it in 2010, allowing EPCS if certain requirements are met. Before I get into the certain requirements, let me point out that it is an interim final rule, but don't put a lot of weight on that word interim. DEA and other federal agencies have several, like a lot of rules that have been interim for years. So this rule is here. It's in effect right now, and it's something that we need to consider following as it is. I don't anticipate any major changes. The requirements, back to the requirements though, at a high level, those requirements include several things, such as, first of all, the State Board of Pharmacy must also allow EPCS. Good news is, as of today, at least 49 states allow the electronic prescribing of controlled substances in some form. Now, New York is particularly interesting because it's the first state to make EPCS mandatory. The legislators there passed a law known as the iStop Act that requires all medications, both controlled and non-controlled substances, be prescribed electronically. And the deadline to comply with this is March 27th of 2015, March 27th of this coming year. So we expect New York to serve as a bellwether, and I know that other states will be keeping an eye on this and monitoring the impact of this law real closely. If it's successful, which I anticipate it will be, I think we can look for other states to follow suit. But let's get back to the DEA rule. It also requires pharmacies, the pharmacy systems, to be certified to receive the prescriptions for controlled substances electronically. And today, about 40% of the pharmacies are ready, but they're all working on it, particularly those in New York. Other requirements include the prescribing part of the EMR, certification of the prescription system, and the use of a FIPS-compliant two-factor authentication modality by providers when signing an order, which David will get into in more detail after me. Now, while those high-level requirements have, for the most part, been satisfied, there's a number of additional systems requirements for EPCS. Some of them hospitals and doctors' offices need to do, and a lot of them the vendor needs to do. First of all, from a hospital or a physician office standpoint, there must be a method for ID proofing. The people that sign the prescriptions have to have a valid DEA in good standing, DEA registration in good standing, a valid state registration in good standing, and if the state issues a controlled substance prescribing authorization, then that, of course, has to be valid and in good standing. That responsibility falls, in the case of the hospital can do that part. Hospitals already have well-established credentialing offices, and hospitals already do this, so that's something DEA will allow a hospital to do. In a physician's office, one of the DEA-registered physicians must get an outside credential from an outside source, and then that person can do can supervise the rest of the ID proofing and some of the others. The second thing that the hospital or the physician's office has to do is there must be a method for assigning appropriate levels of access. Nurses may be able to enter the prescription, but only the physician or the prescriber can sign the prescription. And so there have to be different levels of access, both for the ID proofing and the access methods. The lists are developed by one person. They have to be countersigned by another. So two people must be involved. In the physician office, of course, the one that approves the list has to be the one with the two-factor ID obtained from the outside source. For the access levels, it's not a requirement, but I strongly suggest that the two people be from different departments, maybe IT and medical staff office, something. But that way, only those that can sign the prescription legally are able to do so. Third is, and this ties into the appropriate levels of access, must use two-factor ID in order to sign, and so there has to be some mechanism. Your vendor can help you do this, but whatever you use, fingerprint, token, whatever, there has to be some way to do two-factor, which again David will explain. Now, some of these changes your vendor does, not the end user, but you need to verify that they are part of the system. Once a prescription is issued and is signed, in other words, using two-factor ID, no changes to the prescription can be made. Once it's out, it's out. If it's wrong, it can be canceled and another one can be reissued, but you can't go back in and change it. Once it's transmitted, the prescriber may not print it out and give it to the patient. So those are all things. Now, the signing with no changes, the transmitted, no printing, those are your vendor responsibilities. Those should be in the system when you get it. If we can move on to the next slide, please. If the transmission fails, there will be notification coming back either from the switch or from the pharmacy that the prescription never got there. Then the prescription can be printed out and handed to the patient to be filled wherever the patient wishes, but that prescription must make note of the time and date it was issued and what pharmacy it was transmitted to. When the patient presents that paper script, the pharmacist has to verify either within their own system or by calling the other pharmacy that the script, the eRx, never got there. Of course, like all good computer systems, there has to be an ongoing audit trail of all activities. Everybody who does everything to the system, there has to be an audit. Again, that's a vendor issue, but it's something you want to make sure is there. The system has to audit and report discrepancies like unauthorized access attempts and other potential problems. So the system has to be looking for problems and let you know what they are. Once you find them, you have to notify the vendor, and if they're serious, the vendor needs to make sure that the system is pulled offline until it's fixed. Here's the most important part of all that I want that everybody needs to focus on. As you look to go to electronic prescribing, your system has to be independently, that's an outside third party, audited to ensure compliance with the DEA requirements. Now, it may be a SysTrust or a WebTrust auditor, but they're not doing a SysTrust or a WebTrust audit. They're doing a specific audit of the DEA requirements, And in order for the system to be used, that audit must document that the system meets all of the DEA requirements in the rules. So the pressure is on the vendor to produce that audit. But my strong suggestion to all end users is that you request and receive a copy of that audit, and you verify for yourself that it says that it meets all the DEA requirements. They are required to give you a copy, and so make sure that you ask for a copy of that audit before you install the system. That way you're pretty well covered. After any major upgrade or significant alteration, in other words, if there was a major problem discovered and the system got shut down, the vendor has to have it audited again before it can be fired up. And then at least every 2 years there has to be another audit, so that nothing, at least there's some attempt there to make sure that the system is still secure as it was on the day that it was installed. What the end user needs to do, though, is fairly simple. Just be able to do identity proofing, be able to determine who has access to what functions, and then make sure that the system is independently audited. Those are the three big things from the end user that need to be done. With that, I'll turn it over to David Ting, who will discuss how to get started with an EPCS project.
Great, thanks, Bill. The first step in starting an EPCS project is obviously to understand the IFR. The IFR is full of details around the authentication requirements that must be met in order to be compliant. Many of the references made within the IFR are highly technical specifications with huge amounts of details, such as the NIST SP 800-63 document that describes what it means to meet the authentication requirements. The key to developing your EPCS strategy is to first understand the DEA's primary goal of building a chain of trust that can bind an electronic script to a prescriber. Today, that association is done using the controlled substances prescription pad and the prescriber's signature. In a digital world, this means providing a digital trail that starts with establishing the identity of the prescriber, enrolling or binding a credential such as a fingerprint or a hard token to the identity, controlling access to the prescribing application through some second factor authentication that verifies when that transaction took place, and then making sure there's an audit event of that authentication event. The purpose for this chain of trust is to ultimately allow the audit records to scroll back to that event to prove that a user's credentials were actually used to sign the script, and then having additional enrollment and identity proofing records to prove those scripts belong to the prescriber. This is all done to reduce the possibilities of forged pads and forged prescriptions and ultimately control drug diversion. When it comes to adding security to a clinical workflow, the adoption by the end user is probably one of the most important components, or the whole system will fail. Some of the lessons we have learned in the past, I'll quickly summarize. First is make the whole process of user authentication easy. This is especially because the task has to be repeated for every patient. The IFR requires the prescriber to present 2 of the 3 authentication modes that we show on the right for every script that has to be signed for the patient. Something that you are, a fingerprint biometric, something that you have, it could be a token, a FIPS password generator, or a smart card, and something you know, a password. 2 of those 3 must be presented to verify the prescriber's identity. The second lesson is really educate. You can't stress enough the importance of making sure the prescribers understand why and what they're doing up front, and to address all the workflow, privacy concerns, and most importantly, any kind of exception handling that may occur. It is essential to make sure prescribers know how to deal with those everyday glitches that always present themselves at the wrong time. Some example might include, what if the fingerprint stops working at that workstation, or what if I have to interrupt my workflow midway through the process? The more prepared the prescriber is, the more successful you will be in rolling this out. So it makes sense to make sure that they're fully educated on how to use the system. Third aspect is make sure the system works. Make sure all the different clinical workflows are addressed and that the system is reliable. Think through whether you're optimizing for in-hospital use or remote use, and how to address a clinician that may possibly have to do both. Streamlining the signing experience in our so the authentication step is not onerous for the user has huge paybacks, as this becomes a huge bottleneck and it will be the first point of complaints from your clinician. System reliability with full failover capabilities to provide continuity service is similarly important and something that you need to think through. EPCS is already happening today. We have many customers that are currently driving successful EPCS projects. Here are some of the best practices we've learned and heard from our customers. One, make sure your local pharmacies are EPCS ready and aware that they can actually accept electronic prescriptions for controlled substances. We've heard of stories where EPCS scripts were sent to pharmacies that actually rejected them. Two, let providers know which pharmacies are not ready so patients are not inadvertently sent to the wrong pharmacies. Three, and I think this is a key one, make sure you have a physician champion that understands the regulations and can drive the changes within the organization that are required to deploy EPCS. The champion ultimately has to convince their peer physicians of the value of EPCS to get the ball started, and also to be that positive driving force. Four, pull together a cross-disciplinary team that has the ability to make key decisions, and especially around authentication workflows, as that is the component that affects all clinicians for all the scripts that they fill or refill. Something we talked about earlier as part of the education, build training materials to inform your prescribers on what they need to do. This is especially important as EPCS rolls out. And also make sure all your workstations are enabled for EPCS transactions, and label them if there are devices that need to be associated with them. This is especially true for fingerprint biometrics. If you're using that modality, make sure they're rolled out at enough locations. And as with any workflow change, constantly test, review, and accept feedback to improve the workflow. Work with your vendors, let them know what works and what doesn't work so they can help you improve that process. And find a vendor that is willing to do that. So Imprivata has a microsite that's dedicated to EPCS. It's under www.imprivata.com/EPCS. Attendees are encouraged to visit the site to find additional information that we may have quickly covered in this webinar.
Okay, thanks. Now we'd like to open it up to the audience for questions. As a reminder, use the questions section on the GoToWebinar panel to submit your questions to the speakers. The first one, which authentication methods of the two-factor requirements are being most rolled out in Epic or Allscripts systems?
This is David. I'll answer that. I think most of our customers today are rolling out fingerprint biometrics together with passwords. That tends to be for an inpatient use or acute care use. That seems to be the way most of our customers are going.
This is Sean speaking. I think that a lot of places are also realizing that they need a combination of workflows, and for many high traffic areas like pain clinics and orthopedics and places where patients are discharged from the hospital or the emergency department, in many of those cases, as David said, they're choosing to put biometric device in for fingerprints for ease of use and frequency of use. but they also find that a lot of people have mobile workflows. So hospitalists, for example, as they're roaming around the hospital, may or may not be able to get in front of a computer to sign some orders and get people discharged or do what they need to do around prescription workflows, and also people that are mobile and out and about as continually the healthcare system grows and you're not just simply within the four walls of the hospital all the time. People in those cases are finding that at least a certain percentage of their providers like to have mobile tokens, like OTP tokens. So I think many of the larger systems especially are recognizing that a mix of approaches might be needed, with the preferred approach being fingerprint biometrics augmented by OTP tokens.
Okay, great. Is there a public list of vendors who have been audited or approved, and if so, where would one find that list?
Oh, this is David. Actually, I think the DEA site under DOJ diversions has a site that lists all the approved vendors. SureScripts also has a list of EMR vendors that have certified solutions.
Yeah, this is Bill. Those are two different lists. The DEA list lists those people that they have authorized to do the audits, the third-party audits. DEA does not list the vendors, the system vendors that have passed those audits, but SureScripts, at least SureScripts told me a long time ago that they were going to keep track of those for people so that they could find out. So the SureScripts list should be the prescribing systems that have passed an audit. The DEA list are those auditors who are doing the audits approved by DEA.
Okay. What is the average cost per provider to implement the necessary two-factor requirements?
I guess it depends on the EMR solution. It depends on the modality. It really does depend on the size of the deployment. We'd be happy to take that question offline.
Okay.
If the attendee wants to contact.
I can pass that information along to you. Is there a particular process that one must follow to register as the person who will register providers?
Do you want to do that, David, or do you want me to?
Bill, why don't you take that one?
Well, if it's in a hospital, the DEA will allow the hospital to do that on their own, just through the credentialing office, and then, like I talked about, another group to assign the access to the parts of the system that each individual is supposed to have access to. In a private physician office, one of the physicians will have to go to an outside source and basically get a fingerprint or get a two-factor ID of some sort. Has to be an approved, a DEA-approved source, and then once that individual has their two-factor credential, then that person is the one within the physician's office who will assign the access and allow people to get into the system. David, do you remember that there were two providers of those credentials, and I don't remember their names off the top of my head?
For identity proofing?
Yes.
So there's actually, you can go to any CSP. There are, I believe, 6 CSPs that can do this, but most of the, and they're listed also on the DOJ site. It has to be has to be certified by the GSA for identity proofing. They ultimately go back to Equifax and Experian as the identity proofing to take additional factors that are related to information that only the proper, only the right individual would know those kinds of financial information. But there's a number of CSPs, credential service providers, that can actually do that, but they ultimately go back to those two identity proofing companies.
Okay, this person wants to know, they currently use proximity badges with Imprivata, and they want to know if those would count as an acceptable smart card.
Unfortunately, proximity cards were allowed under the Ohio Board of Pharmacy Positive ID program, but the DEA has much more stringent requirements, and the cryptographic capabilities found in proximity cards currently do not meet the DEA's specifications for as a factor, as a physical token. We do know of several vendors that are trying to get their solutions, their physical cards certified, but right now there are none that are approved.
Okay. Do you know what the readiness of the pharmacies is? Would one have to contact each one, or is there a list of pharmacies that are ready?
SureScripts is one of the sources that would know. A lot of the chains are working very hard. If you contact one store in the chain, they will be able to tell you about all of their chain stores all over town or all over the county. So right now, though, about the only way other than SureScripts that is supposed to be keeping track of who can talk to each other and who can't, or who voluntarily said they'd do that, the only good way to find out is to call. Both ways, for the pharmacy to check with the prescriber and the prescriber to check with the pharmacy.
And this is Sean. I would back up Bill's point that even if technically a local pharmacy comes on board and CVS or SureScripts or anyone says they're on the list of approved pharmacies, it's definitely worth going the extra step, and as a healthcare provider and institution, maybe having the pharmacist or someone on the healthcare provider and call that pharmacy and make sure that from a policy and culture change level, they understand that when prescriptions start to come through, that the person on the other end, the pharmacy tech or the pharmacist or whoever gets that prescription coming through, recognizes that they are actually allowed to accept an electronic prescription for controlled substances. So there's sort of a second step that I think just the due diligence, it would behoove everybody to just double check and make sure that the local pharmacies that they commonly prescribe to are indeed on board.
Can you talk a little bit about batch ECPS? For example, can a nurse queue up 30 or 40 scripts and then have the provider approve each one?
Yes, and actually you can do it by patient. That was one of the discussions during the rulemaking process. And so if John Doe has 5 prescriptions, 3 of which are controlled substances, the doctor can review all 3 of them, authorize all 3 of them, and then sign all 3 at once. You have to, the prescriber must sign for each patient, however. So out of those 30 scripts, if there happen to be 30 patients, one script per patient, then the prescriber would have to sign each one. But if those 30 scripts were only 6 patients, well, that's a lot of controlled substances per patient. But anyway, the prescriber would only sign 6 times. In other words, once for each patient is all that's required. That, of course, is also going to depend upon your system vendor and how they have that set up. But under the DEA regulation, you can sign for a patient.
Can you talk about how disruptive it might be to have multiple workflows when e-prescribing?
This is Sean. I mean, I think there are certain parts that may be disruptive and certain parts that can be helpful. I think it very much depends on the technology employed. I know we're working hard with other vendors and with healthcare systems to understand exactly what's needed. I think that making sure the authentication events and knowing either on a location base, knowing whether there's a fingerprint reader hooked into the computer that the prescriber is on, and knowing whether that person has enrolled their fingertip or whether there's an OTP token option available. If the system's able to do that and make a smooth transition for that provider, then in fact it actually could be less disruptive. Right now, when a doctor is going around and trying to discharge a patient from the hospital, they may have to print the discharge medications and physically walk up to the floor where those medication prescriptions printed, where the patient is actually located, find those prescription papers which may be sitting on a printer somewhere out on a floor, or someone else may have picked them up by mistake, or all sorts of things can happen that are potential HIPAA and security violations and inefficiencies in the system. Walk around, find those things, sign them all, go find the nurse or the secretary and hand them to them. And you can imagine the number of delays that can happen between actually wanting to print out a prescription and let the patient be discharged home to the point of walking over and doing that. So right now there's a lot of disruption in poor workflow as is. I think you substitute and trade certain benefits and detriments by picking up the electronic system. So I think that's a long answer, but the short answer is the devil is in the details of how you construct your system and integrate it into the fabric of your daily workflow to make it easy for providers, but also maintaining the security and audit trail that is necessary. And some of that gets down to these authentication events and making sure, as we discussed before, you have the right methodology employed in the right places, and you make it easy enough for providers not just to do the easy thing, but the right thing at the same time.
If a patient has 2 controlled scripts plus 2 non-controlled scripts, can they be done in one session even with the heightened security, or will that require it to be done in 2 sessions of approval and transmission?
This is Sean again. I know the way we're constructing our system in conjunction with a lot of the e-prescription systems with EMR vendors, the answer is yes. The system will just prompt you automatically for a higher level of authentication, the second authentication, if required, and otherwise it will not bother you with that. I can't speak for all systems. Again, a lot of it is in the details of how it's actually deployed and whether there's enough background intelligence in the system to recognize the difference in those events. Those triggers typically come from the e-prescription system built within the EMR. So there are some moving parts in coordinating that information with the authentication delivery system. So I can't speak in total for all systems, but a well-constructed system should do that and allow the provider to sort of batch that and only be prompted when necessary for higher level authentication events.
Okay. Can you describe how compounded meds that contain controlled substances will be handled?
They're going to be handled the same way. The system will have to prepare the prescription. It'll contain a controlled substance, and so from a security standpoint, the physician will be provided with that prescription to review, or if the physician entered it, obviously it's already there, but the physician will still have to physically authorize that script and then sign it using 2-factor ID. It really doesn't matter what kind of a prescription it is if it contains a controlled substance. Let me add one thing I forgot to add. Right now, these rules apply to outpatient prescriptions. They do not apply to in-hospital inpatient prescriptions that go down to the hospital pharmacy and the meds come up. So these are only outpatient prescriptions, but it doesn't matter if it's a controlled substance. It will be presented. Your vendor should have it set up so that it's presented to the prescriber for authorization and for signature.
Okay. Is it possible for a single provider to have multiple methods of authentication? For example, if they have a fingerprint technology available at one location and a token or smart card would be available for use at another location that didn't have the fingerprint device?
Sure, it's fine. They could have one system. They could have a fingerprint within the hospital and another technology at home if they did some prescribing or some, patient activities from home. If the hospital allowed that system, they could have two different. I don't know. It just has to be two-factor ID. Nowhere in the rule does it specify that it has to be the same across the board.
Yeah, this is Sean. I agree. It's definitely allowed, and it's preferred from a workflow standpoint. I would just make sure that everybody as a healthcare provider does due diligence on the system to figure out and make sure that it's configured in a way that allows for that. But I highly encourage that because realistically workflow for clinicians is such that certain modalities work better in certain scenarios and may work better in other scenarios. So definitely encouraged.
What other states do you think will begin to mandate e-prescribing, and specifically this person is interested in when New York might do so?
New York already did so. That March 27th of 2015, all scripts have to be e-prescribed. That law is pretty straightforward, and everybody's kind of watching that to see what happens. There's a lot of discussion going on in New York right now about how to implement that, but from what I've heard, there's not a whole lot of bending on the part of the state. And so New York, according to their legislature anyway, by March 27th of next year, every prescription issued by a New York prescriber will be electronic. Assuming that goes through, I think you'll find a lot of other states looking at that with a great amount of interest.
Yeah, this is, oh, sorry, Bill, go ahead.
No, go ahead. Go ahead.
This is Sean. I just wanted to support Bill's point and say that the iStop law in New York has really pushed a lot of this forward at an accelerated rate. It's requiring that all systems be, all controlled substances be written electronically and compliant with the DEA mandates or regulations. And additionally, it's requiring everybody check the prescription monitoring program. In addition to performing all electronic prescriptions of controlled substances. One thing this has done on a national basis has pushed a lot of the vendors to actually get their systems up and built and certified. So I think other states may find once this continues to play out in New York over the next few months and a lot of these systems come to more maturity all the way through that chain of authentication and security that David and Bill described, I think it's going to actually prove out the model for other states, and hopefully, a lot of the wrinkles will be kind of taken out of it as it moves forward through to other states. But definitely, New York it's been passed, it's a law, and people need to be compliant with it.
Yeah, I think there's one additional wrinkle that I just want to add, which is if you're in an adjacent state to New York and you have patients that are in New York. If you're, let's say, in Vermont and you have a New York patient, the doctor who's electronically prescribing medical controlled substances for that patient, and that prescription has to go to a New York pharmacy. The only way that New York pharmacy will accept the order will be if the Vermont hospital is similarly using an EPCS-ready solution. So this halo effect is going to affect all the adjacent states. Especially around the border hospitals where they also need to be compliant with that iStop regulation.
Can you please comment on e-prescribing of non-controlled substances for prescribers in Ohio? I understand that two-factor authentication is needed for EPCS and non-EPCS. What hospital workflows are you seeing?
We, since the mid-90s, we've required what we refer to as positive identification, which was something other than or besides a password. We were a lot looser than the DEA final rules, but we were trending towards two-factor ID. So we required that for all everything that involved drugs, the prescribing, the administering, and the dispensing. So prescribers, nursing, and pharmacy all were impacted by that. And we held hospitals equally accountable with outpatients. So, the people in Ohio have been hearing this for many years, but not quite as stringent. Once you go to e-prescribing, one system for controls and non-controls, then you'll be using two-factor for everything, probably. Then you'll meet the Ohio requirements without any problem.
It's my understanding that the New York regulations also affect inpatient orders, including nursing homes. Is that your understanding as well?
First of all, nursing homes are not inpatients according to DEA. Nursing home patients are outpatients because the nursing home is not a DEA registrant as the hospitals are. So a hospital inpatient is an inpatient. A nursing home inpatient is not an inpatient under the DEA interpretation. They are outpatients, and they have been held to the same standard as most of us getting prescriptions. We're talking controlled substances now. Most states do not agree with that. However, it's the federal interpretation at this point. So nursing homes right now to DEA are outpatients.
Okay, the DEA ruling is not final, so why should we worry about EPCS since it'll probably change?
Well, I addressed that. It was an interim final rule, but there are a lot of interim final rules existing in the Code of Federal Regulations that have been interim for years and years. It's possible that it will change, but I don't, in discussions I've had with people at DEA and around the country, I don't think that it's going to change significantly. I don't see two-factor ID particularly going anywhere anytime soon. The rule is here. It's ready to go, and it should not be any, I don't anticipate any major changes to it anytime in the near future.
Do any of you have any information about providers applying for waivers, for example, a provider group that doesn't have an EMR to prescribe with?
That'll be the New York, I assume. Either of you two have an idea?
So this is David. The last time we spoke to, we were in New York and spoke to the New York Board of Pharmacy and the Narcotic Bureau of Enforcement. They said they are working with different medical societies and different groups to make sure that if for some reason a waiver is required, that they would be actively working with those groups to make sure that those waivers are available. But they did not define or list out what criteria they would accept those waivers. So it's on a case-by-case basis as far as we know. Okay.
For those of you who have not had your question answered, there have been a lot of very specific questions asked by current Imprivata users that I will pass along to the Imprivata team and have them contact you to answer specifically to you. And also those of you who have asked for them to contact you, I will be passing that information along as well. That was our last official question and the last one that we're going to take, so that will conclude our webinar. I want to thank you for joining us today and for a really good, interesting, interactive session. Thank you, Dr. Kelly, Bill, and David. As a reminder to attendees, watch your email for links to the recording of today's webinar as well as a PDF version of the PowerPoint presentation. We look forward to seeing you at a future HIS Talk webinar. Enjoy the rest of your day.